Hello and welcome to a University of Utah School of Medicine Wilderness Medicine lecture. My name is Paul Schmutz. I am a practicing dentist, and today's lecture is going to be about treating teeth in the backcountry. So let me share my screen with you, and we will begin this lecture. So when we look at the backcountry, I hope to share with you some tips, tricks, and hacks that will hopefully make your visits into the backcountry better for people who might have trouble with their teeth. And when we look at this, dental emergencies really do happen anywhere. They happen in the backcountry. They happen on day trips. They can happen at the park. They can really even happen in the backyard. So dental emergencies happen everywhere and anywhere. And we're not just talking dental trauma today. We're also going to be talking about dental infections that may occur. So let's say that you are on Cataract Canyon, which is located in the southeast corner of the state of Utah in the US of A. And someone in your group shows up. Let me back up and tell you where it is. It's at the confluence of the Green and Colorado rivers, about 30 miles from the nearest road, and probably hours and maybe even days to the closest help. And if someone in your group wakes up in the morning and has a swollen cheek like this, are you able to treat them? And if not, are you going to phone a friend? So hopefully in today's lecture, we're going to increase your knowledge and improve your toolkit so that you may be able to treat something like this and make their trip better and continue on their way. I know a lot of times we go into the backcountry and we may only be a few hours away from help, but there are trips that you might take that could take you much further away from getting help and the necessary needs that you may have. So today our focus is going to be on the toothache, on dental infections, on dental trauma, and soft tissue injuries that may come along with that trauma. Let's begin with the just a quick basic tooth anatomy. When we look in the mouth, we usually see this outside layer of the tooth, what we call enamel. That's the crown of the mouth. It's made up of really just a hard rock or crystal called hydroxyapatite. The next layer down is dentin, and it's filled with lots of little tubules that have fluid in them. And then our next layer is what we call the pulp chamber. And in that is the nerves, the blood vessels, connective tissue, lymphatics, all the soft tissue, basically the neurovascular bundle. So for the next 40 minutes or so, we're going to spend a little time in my world, and hopefully you'll come away with a little bit of knowledge to be able to treat people. As we look at the toothache, we want to look right at the pulp. And what this is an inflammation of the pulp. It comes in two flavors. It comes with a reversible pulpitis or irreversible. And really both of those are going to be either symptomatic or asymptomatic. Obviously, the ones that are asymptomatic, they don't bother people. They're probably not going to know about it or even bother you with it. But the ones that do, someone may say, hey man, my tooth is really hurting. What can you do? For most people, they are just going to take something for the pain. But let's discuss what's causing that and some possible treatments. As we look at reversible pulpitis, as we remove the cause of the problem, usually that tooth will settle down and get better. Unfortunately, with irreversible pulpitis, as we remove the cause, the etiology, the nerve, the blood vessels, that pulp chamber may be at a spot that it's no longer to heal itself. And so the aching may go on, so further treatment might be needed. So as we look at this, the cause of these are usually caries, which is just our word for saying tooth decay. And it could be a defective restoration. It could be some exposed dentin, and it even could be some trauma that disrupts the blood supply to the tooth. The symptoms differ slightly in that with reversible pulpitis, it's usually when the stimulus gets on the tooth that the tooth gives us a response. And usually it's a quick one. So I put something cold on the tooth. You go, ooh, I feel that. You take the cold away. Within a few seconds, the tooth feels normal again. On the reverse side, the irreversible pulpitis, that pain is going to continue to linger anywhere from a few seconds to even a few minutes or longer. They might have spontaneous pain. They could have pain when they bite on it, and the pain could be referring out to other spots. They could feel it in their ear. They could feel it in other teeth. Here are some examples of some caries or tooth decay. They could be sensitive as someone puts something cold or hot in their mouth, or even something sweet. And if we were to treat that, we could possibly get rid of it. Cracked or leaking fillings do the same thing. It allows for the bacteria to invade and for temperatures to get down in there. Sometimes people bite down on something hard and break a corner of their tooth off, exposing the dentin, and that can be sensitive. So the treatment for reversible pulpitis is fairly straightforward. We're going to put a filling in there, and if they're having pain, we're going to give them something for that. In the office, I'm going to put in a filling. In the backcountry, we're going to do the same thing. We're going to put a temporary filling in that tooth to help protect it, make it feel better, and be able to enjoy the trip. We have all kinds of different temporary filling materials. Up here, this Cavit and Temperin is pre-mixed for you, so you don't have to worry about mixing it. Where the IRM and the ZOE, which are basically kind of the same, they're a powder that mixes with eugenol to be able to place in the tooth. And you could use something like some soft wax, ortho wax that kids put on their braces. It's soft and you'll be pushed into little nooks and crannies or holes on the tooth. And you could even resort to some gum. So when we look at reversible pulpitis, a stimulus hits the tooth, it makes it react, and all we're trying to do is block that stimulus by placing a filling on the tooth. As you can see here, the filling is on the tooth. We have a little bit of excess up here. All you need to do is have the patient bite down, take a wet Q-tip or a wet finger and just kind of rub on it and just get rid of the excess so that when they bite down, it makes their bite feel like it's normal and not hitting over there. Now, obviously, you're going to put that in when it's kind of soft, so that softness will help to mold that bite a little bit better and make it more comfortable for them. When we get into irreversible pulpitis, now we have a pulp that even if I put a filling on it, it's still going to be an achy tooth. So we need to probably put in a soothing medication first, and then we're going to fill the hole and then give them something for pain. So if we just put the filling in, it may even aggravate the pulp chamber, that neurovascular bundle that's already in there. So what we want to do is place something between our filling and the nerve so that everything can kind of settle down. One of the best things we have is called eugenol, and that temporary filling material I talked to you about is we often use eugenol to mix with it. So then we have that mixed into the temporary filling material. If you don't have eugenol, clove oil actually is almost the same thing, and it works to help soothe the tooth. And what you want to do is take some cotton pellets or the end of a Q-tip and cut off the end so you have a small amount of cotton there, or a cotton ball, and cut it up and soak it in the eugenol or clove oil and place it in the tooth and then cover it up with a filling. I've also read that you can take just regular cloves. So if you don't want to carry a lot of weight, if you're going backpacking, you could just take cloves and then you can bite down on them or have the patient bite down on them to release the oil that's in them, and hold that over the tooth for a while and try to get some relief. So as we look at our little toolkit that we're going to build here, our first aid kit, we're going to want to put in some sort of temporary filling material. We're going to want to try and put in some soothing medication, and then we're going to want something for pain. A couple home remedies that that when patients call me at home on the weekend, that I have them try to do if they're not getting pain relief from ibuprofen or Tylenol, is have them use, some garlic that has some antibacterial properties in it, and that can help to soothe the tooth, along with an onion has kind of a similar type of thing and can help stay that off. Baking soda, either as a rinse or dip a toothbrush in and then kind of brush over that tooth with baking soda, helps to relieve some pain. And or they can rinse with some hydrogen peroxide. Recommendation is to rinse with half strength. So take your 3%, half 50-50 water, hydrogen peroxide, and rinse with that every few hours or as needed to help relieve the pain. Our temporary filling material is great to use on restorations that someone might have knocked out or it comes loose. Basically, what we want to do is we want to either mix it up or take the one that's already pre-mixed and basically just clean out the tooth the best we can, have them rinse, brush, whatever the case may be, and then fill the hole. If they had a crown that came off, for those who don't know what a crown is, it's a type of restoration that goes around the whole tooth to help strengthen it. And sometimes they'll come off. The cements that hold them on get weak, or they may get decay into the tooth. What we want to do is we want to clean out the inside of the crown that has any particles in there, any loose cement. We call this the intaglio surface. And then we want to try it on the tooth to make sure we know the orientation and that it actually fits. And then in this case, I took some tempera and I just filled up the crown. Now this is a model I had of a crown, and put it on the tooth, and all the excess gets pushed out. And then you can come along and just clean that off the best you can. If you don't clean it all off, that's fine. When they go to see the dentist, we can clean off anything that might be left behind. All right, we're going to shift gears slightly here and talk about dental infections. So we've talked about pulpitis and the two flavors it comes in. A reversible pulpitis, if left untreated, will eventually turn into an irreversible pulpitis, which could then turn into a dental infection. That's sort of the flow chart that we're going to see. And dental infections can either come from the tooth or they can come from the gums. As we look at an infection that comes from the gums, that could be common in the backcountry if you're dealing with kids who are 18 to 24, is a condition called pericornitis. And what this is as that third molar or that wisdom tooth is erupting, we're getting food impaction or bacteria underneath that little bit of tissue that's still on top of the tooth. So this is going to be in kids that are 18 to 24. That's when wisdom teeth come in. The swelling is going to be very localized, just around or over that tooth. The pain could be intense. In some cases, they're unable to open their mouths very wide, and sometimes they can't even stick out their tongue. So those are two kind of differential diagnoses that you could use if you wanted to. But basically, if you look in there and see redness around the very last tooth that's coming in, then you know you have a pericornitis. Treatments are going to be, we want them on antibiotics. We want to give them something for pain, and we want to try and get that, whatever is getting caught underneath that tissue out. So either a warm saltwater rinse, or if we can get under there and irrigate with something to clean it out, that will help. And here's just an example of the tissue. In the top picture here, that tissue is nice and tight, so we're probably not going to get a lot of food impaction underneath there, but you can see this loose one here could get something down underneath there and cause some irritation. So now let's look at an infection that comes from the tooth. An odontogenic means from the tooth. And the most typical one you're going to see is the apical abscess. And that's going to be either an acute one or a chronic one. With the acute one, we've had bacteria that has come in from the tooth and is now at the apex or around the apex of the tooth. And the etiology is really from bacteria, either from a deep cavity that's on the tooth, possibly a cracked tooth, trauma that has occurred on the tooth, meaning that it's been bumped at some point in time, and or they may have some gum disease. Here is a nice schematic that shows our maxillary tooth, molar, and that infection starts inside the tooth somewhere and now has come out of the tooth and is finding its path of least resistance. And now we're getting some swelling along the gum line there. So again, that swelling is going to be pretty well localized. And because of the swelling, it's building up pressure. So we get some spontaneous pain. We could also have continuous pain on there. And people also report that when they bite down, that they're feeling pain when they bite down. If it's been going on long enough, the nerve that's inside the tooth now becomes unresponsive due to the infection. And so now it's no longer sensitive to hot or cold like it was when we had the pulpitis. And a lot of times we'll see tooth mobility as that swelling occurs because it gets into the periodontal ligament space. So the treatment here is going to be antibiotics, and we're going to give them something for pain. And then we may want to consider, depending on our location and how much this infection is bothering them, an incision and drainage. So if they have a large, soft mass above their tooth and the gums there, you can take a nice little sharp scalpel and just make an incision and see if you can get something to drain. Here's one. Here's our apical abscess. An incision is made. Now, what happens is a lot of times the infection is really behind the bone, so you may not get a lot of drainage. And so in that case, we may have to go in and open that up a little bit more to try to get some drainage. And then if we were in the office, we'd install a little drain to have that continuous drain as things heal up. In the backcountry, you probably just make an incision and see if you can get that to drain. Let's move on to chronic apical abscesses. This is basically an acute apical abscess that has been there long enough that it has developed its own drainage tract, its sinus tract. You can see here that as that infection builds up, it gets this little bubble that we often call a gum boil. So as we look at them in comparison, the acute versus the chronic, you can see that they're following the same path. This one has just decided to develop its own drainage on its own. So what are our findings with the chronic one is that little gum boil I just mentioned. We usually have a tooth that's loose. Some people feel like it's a tooth that when they bite down, that's what they hit first. So it's kind of a raised tooth. I had a patient once a few years ago that he came in and had an infection down there, but every morning he said he'd get up and he would just kind of mash the tooth back into its socket, and then he'd go throughout the day. So a lot of times these chronic infections are pain-free. They're more of an annoyance, and because they're kind of draining on their own and they're not building up any pressure. So when we look at treatment, obviously we're going to put them on antibiotics. Do we need to do an incision and drainage? Probably not, because it's probably doing that already. And depending on if they're having pain or not, you may or may not need to give them anything for pain. The key is that after the trip is over, you should recommend that they go see the dentist so they can get proper treatment done. So we've looked at the acute and chronic infections coming from the tooth, and now we're going to look at these fascial space infections. And as you can see from that diagram, those infections can go out in any direction from there. Most of them go out to the side, but if they happen to go into another area, they might get trapped and into the different fascial layers. And with that, it's an easy highway because those segments are just kind of laying together. And as the infection grows, it just kind of keeps pushing and pushing. So from this diagram, you can see the different areas you're going to go into. We have a submandibular area here, a sublingual area here. Now, the danger with these ones is if they continue to the other side, it can start to block the airway. And then the ones that are up here in the canine space, front teeth, can get into what we call the danger triangle. And as they swell up, some of that infection has the possibility of going deeper down into there and could actually end up in the brain. So we are obviously concerned with those. So the signs and symptoms that we see with fascial space infections are obviously the swelling that comes with it. People may have difficulty swallowing. They'll have a temperature. They can have chills. They may not be able to open. They don't look good and they don't feel good. And you can kind of see that. The treatments, again, we're going to put them on antibiotics. We'd love to put them on IV antibiotics, but that's probably not available in the backcountry. Obviously, we're going to watch the airway to make sure that they don't lose that. Definitely consider evacuation. So depending on where you are on your trip and how quickly you can get out, the trip may be over for them or for everybody. And obviously we can do an incision and drainage. So here's a patient who I found on the internet who had a buccal space infection, and they made a small incision and got some drainage out. And then this is a few days later because his mustache has grown in a little bit more than that first picture, but you can see that that swelling is just about gone. I have no idea if they put him on antibiotics. I'm assuming they did, but he's in better shape. So we're back on Cataract Canyon. The question I have is, what is your ability to treat? I think it boils down to these four things. What knowledge do you have? Do you know what's going on? Are you comfortable treating this person? Do you have the proper instruments to be able to treat them? And really, how far away is the dentist? If the dentist isn't too far away, then you just pack them up and take them to the dentist and get their treatment. But if not, you can do a little treatment yourself. So let's add a few more things to our toolkit. We're going to use a light source because in the mouth, it's kind of dark. And most people, when they go into the backcountry, usually take something with them. A lot of people have lights or a flashlight on their phone these days, and they usually have that as well. So we're pretty well equipped. The question is, what instruments should we take and what antibiotics should we take? As far as instruments are concerned, we might want to take a sharp knife or a scalpel with us, some hemostats, some scissors, have some Q-tips or cotton pellets. We probably had those already in our kit when we added the soothing medication. Things like a toothbrush can come in handy. Even floss is helpful. And so now let's take a look at what analgesics should we take and what antibiotics are best. So what we found in treating teeth is they're painful, and so people want to get rid of that pain. So back in 2013, Paul Moore and Elliot Hirsch did a study, and what they did is they wanted to determine what worked best, and they used the number needed to treat, and the lower that number is, the better that medicine works to treat the pain. And they used Tylenol, 500 milligrams, and they got a 3.2. Ibuprofen, just 200 milligrams, 2.7. And then they used some oxycodone with acetaminophen and got a 2.3. But the surprise, I think, on this study was a combination of ibuprofen with acetaminophen came in at a 1.6. So nowadays, when I do procedures on a patient that I know they're going to be in pain afterwards, I usually recommend to them to take ibuprofen and acetaminophen. I usually have them alternate every couple hours, every 2 to 3 hours with that. I usually bump up my acetaminophen a little bit to somewhere between 400 to 800 milligrams, and that seems to work really well. When it comes to oral infections, it's really a mixed bag in the mouth. We have all kinds of organisms there. The nice thing is that most of them react well to penicillin. So again, the Journal of American Dental Association published an article in 2019, and they gave us a little flow chart here to decide, when it's appropriate to do an antibiotic, and then of course, which one should we use? And the article to me boils down to this. If we're going to use an antibiotic, our first line of defense is going to be either amoxicillin or penicillin. And they've got 3 to 7 days, but I'd probably say 7 to 10 days is what I usually do with that. And then if the person is allergic to amoxicillin and penicillin, then we can come in with cephalexin if they didn't have an anaphylactic reaction to the previous medication, or just go straight down to azithromycin, which is usually what I just head to, give them a Z-Pak and or clindamycin. I have used clindamycin a lot in the past, but I've kind of switched over to azithromycin just because I've seen patients, and I actually had one patient who got C. diff, and I think that's a little bit more common with clindamycin. So azithromycin is the one I like to use. Now, There are some alternative or home remedies, and honey is a great one that seems to fight infection. I actually had a patient once who had been a refugee from Bosnia, and we were talking one day after her appointment, and she was mentioning that she had an infection, and the way she described it, it sounded a lot like this one right here, a submandibular infection. And she said that someone in the camp had told her, because they didn't have any antibiotics there, really not a whole lot of things to treat with, they found some honey, put it on a rag, and applied it externally to that. And she said within a couple of days, her infection was gone. So I did find this article from a tropical journal of biomedicine that talks about using honey as a way to heal up infections. All right, we are going to shift gears, and we're going to get into dental trauma. This is probably why you came to the lecture, to find out about dental trauma. And this is Jake. Jake, who was at a skate park, not in the backcountry, but this can happen in the backcountry. Took a jump and came down and landed wrong. And this is how he presented at my office. So you can see Jake needs a little work here. Before he came to my office, he actually ended up in an Instacare where I think it got cleaned up, a couple of stitches in his chin. This is some photos his dad texted me when they were at the Instacare saying, hey, we need to see a dentist. And this is how Jake showed up to my office. So the staff or medical doctor in the Instacare apparently had some knowledge on some using some temporary filling materials to treat broken teeth. And he came in. I was actually surprised at how well these were stuck on the tooth. I thought once I kind of started pushing on them, they would fall off, but it took a little effort to get that off of Jake so that we could fix up his teeth and send him home with a better smile. So let's talk dental trauma, and that's going to be the hard tissues and the soft tissues, the teeth and the bones, and then the cheeks, lips, tongues, gums, etc. We're going to talk about fractured teeth. We're going to talk about displaced teeth, also called luxated, and we're going to talk about the knocked out tooth, the avulsed tooth. So as we look at fractured teeth, there's a couple different classifications that people use. This one, I believe, is the Ellis classification. I like it because it kind of describes it. And we're going to look at these three fractures. The crown fracture and the complicated crown fracture only differ in that with a complicated fracture, we've exposed that pulp chamber. So we're going to see some bleeding, and those are a little bit more painful and obviously sensitive as well. So the first thing we want to do is we want to stop the bleeding, have them bite on some gauze, put some pressure on that, get the bleeding to stop. Depending on how big your exposure is and how painful it is to them at that time, you could put on some soothing medication, some clove oil or some eugenol. So just soak your cotton pellet in some eugenol and kind of squeeze a little bit drier. You can place it on the tooth for a little while and then put your filling on, or you put it on the tooth and then place your filling. Either way works. We put the temporary filling on, and then we do palliative care, which is really, we're going to avoid chewing on that tooth. We're going to avoid putting things on the tooth that make it hurt. We're going to rest the tooth and wait for it to get better. With the crown root fracture, what happens here is the fracture happens, but there's still some attached tooth to the gum tissue. So it doesn't just fall away. If it were to break above the gum tissue, it would just be a crown fracture and it would just fall off. So the question in here is, what do we do with this tooth? We got a loose piece that's kind of just flapping in the wind. It may be sensitive because we have exposed dentin, and if that little piece comes off, we'll have some sharp edges that may irritate the gum tissue. So the question is, do we remove it or do we stabilize the tooth? And if we remove it, it really isn't attached by very much, so you can just grab it, that loose piece, with your fingers or with a hemostat, and you can see just this bottom couple of millimeters was attached to the gum tissue. And it's basically just like ripping off a Band-Aid on the skin. It'll hurt for a second and then it's gone. It may bleed a little bit. That bleeding is coming from the gum tissue, not from the tooth. And then we can stick a little filling in if we have some sharp edges. If it doesn't bother them, you don't need to bother with a filling. If you want to stabilize it, we're going to take just a little super glue and try and get that as dry as possible, and just stick a little drop in there, and then just push that up against there and let that, and hold it there till it kind of dries, and then they'll be fine. And then you'll want to avoid chewing on that side. When it comes to the complicated crown root fracture, this one is going to be much more involved and something we want to pay attention to in the back country. Here we have a tooth that has the fracture. There's the fracture going down. And so the question is, and when I took that tooth out, it just kind of fell apart. So if you tried to take that tooth out in the back country, then you're going to have to take out either the whole tooth or part of the tooth. And I don't think your patient's going to like either one. So how do we tell the difference? By just looking at the tooth. The key thing here I found with complicated root fractures, crown root fractures, is that the fracture usually ends up right down the middle of the tooth. If you look here, this uncomplicated one, or just crown root fracture, is off to the side of the tooth, where this one actually starts in the middle of the tooth, and then it does make its way out. But anything in the middle of the tooth there, consider that that is going to expose the pulp. So sometimes your teeth will be a little bit rotated. So what we're doing is just looking at that, where's the middle of the tooth, and if that fracture happens along that line, then we're probably going to have an exposed nerve. So I feel that the treatment on here is, one, either just leave the tooth alone and use pain medications to comfort them till you can get them to the dentist, or you could try to stabilize it with some super glue. I don't think you want to try to extract these teeth, because that root going down is going to be much more involved and take a little more effort to get out, and you'll probably want to numb the patient to do that. Let's look at luxation injuries. And we may have seen these in our lives from different people. They are basically teeth that have been hit. Someone's been hit in the mouth with something, and we've got teeth that get displaced. The interesting thing that I've seen is that in most cases, when we have luxation injuries, I don't see fractured teeth. I see the tooth being displaced from the socket. So the injuries here are now going to involve the periodontal ligament, which is what holds the tooth into the socket. It's going to involve the gum tissue, and it's going to involve the bone. So here's our classifications. Let's look at them. Concussion and subluxation are almost the same. The only difference is we may have some mobility with the subluxation versus a concussion. Basically what's happened, someone has been popped in the mouth, and now they have a sore tooth. So basically like a bruised tooth. It's tender to the touch. Our treatment is going to be rest the tooth. If it's loose, we can splint it. If it's slightly loose, you probably don't need to. And then put them on a soft diet and manage their pain. If the tooth gets pushed up into the arch, we have an intrusive luxation. These ones are pushed up and out of the way. So really our treatment really is not to do anything to the tooth, but just to treat the patient as needed. So soft diet, pain management, you could have them rinse with some warm salt water. That could help alleviate some pain. The extrusive luxation, what happens here is the tooth now has been knocked down out of the socket, almost knocked out. It's extremely mobile, and as they try to bite down, it's going to interfere with their bite. The treatment is going to be to reposition that tooth back up into the socket. So you're going to take a finger, or they can take their finger, and just put pressure on that tooth. Now, what's happened is that tooth's been knocked out. It'll cause some bleeding up in the socket. So it won't just pop right back up into the place. We will have to displace a little bit of the blood that has accumulated in there. Once we get it back into the socket, then it'll probably still be loose. We'll need to splint that tooth and then do our palliative care. Lateral luxations are an interesting one, because it's almost like an exclusive luxation, except for we've fractured some of the alveolar bone. And now what happens is that tooth is immobile. When we touch it, it's actually locked into place, but it will still interfere with their bite. So the treatment is we want to get that tooth back into the socket and splint it if it's mobile. A lot of times when these go back in the socket, they're not mobile, so they don't need splinting. So what we want to do is we want to come with our finger, one from the top, and try to feel where the top of that tooth is, the apex, and we're going to push down on that. And while that's pushing down, then we're going to grab with another finger and come from behind and rotate that tooth so that it pops up into the socket. And so that's called the two-finger reduction, and it'll pop right into place. If we have a segmented alveolar fracture, this one was our lateral luxation here, where we had just one section of the bone break, but with a alveolar fracture, we're going to see both sides break. And these are going to be usually very loose, very mobile, and you're going to have a group of teeth. It's usually not just one tooth. It's going to be two teeth, sometimes three teeth together. So these two teeth won't move independent of each other, but they'll move independent of these other teeth. So the treatment on these is to reposition those teeth back into their proper place, and then splint it because it will be mobile, and then palliative treatment. So as we look at splinting, technically with an alveolar bone fracture, we want to use a rigid splint so that we can get that bone to heal up. But in the back country, that's not probably doable. So we're going to stick with the non-rigid splinting, so that all of our splinting is going to be non-rigid. And if it's in the office, I'm going to put something like a small ortho wire on there and attach it to the tooth. In the back country, you can use something like fishing line, dental floss, string, whatever you have to kind of hold that tooth into place. Now, obviously, if you just lay it in there, it's not going to stay. So you need to probably take a little super glue, make sure the tooth is dry, and then just glue each segment to each tooth. Or you could actually take super glue if you don't have any floss with you or something, and just kind of glue the teeth together to the adjacent teeth. We could get creative here. You could actually use tape. Sutures actually is a good combination. I've heard of people using sutures, and it works. In this particular case, there's no adjacent tooth to splint it to, so sutures had to be it. Now, sometimes those sutures will slip off. So once you get the suture in place, a little dot of super glue right there will hold that in place. You could also use ortho wax, or you could just get creative with whatever you happen to have with you. Let's look now at the knocked out tooth. This is the big one, and this one can happen. Our treatment options are, one, to re-implant the tooth right there. We can store the tooth in something and re-implant it later, or take them to the dentist. We could store the tooth dry, but that's really not a viable option. Or we can leave the tooth out and just say, we're going to take you to the dentist and he's going to put in an implant, a dental implant. If you don't know what a dental implant is, it's basically the implant takes the place of the root of the tooth, and then we place a crown over the implant to restore it and make it look like a tooth. So here's an example of someone who actually was congenitally missing some lateral incisors, and the orthodontist moved the teeth into the proper position, and then implants were placed and the teeth were restored. So as we look at the knocked out tooth, the key to a successful reimplantation is keeping the periodontal ligament cells alive. So the question is how long will these teeth stay alive? Technically about 15 to 20 minutes, 30 really at the most. So in 15 minutes time, we need to, one, find the tooth if it's been knocked out of the mouth and is on the ground somewhere. Two, manage the tooth. Three, manage the socket. Four, reimplant the tooth. And of course, take care of any other injuries that the person may have. So if we don't get that tooth back into the socket in that 15-minute window, 15, 20-minute window, then we may have a tooth that's going to die on us. So to prevent that, we want to give that tooth something that's going to keep it healthy and prevent it from getting sick and dying. So we need some sort of tooth storage system. And You could say, well, I have these drinks with me in the backcountry. Can I just throw the tooth into that or clean them off with that? Well, when we look at a storage medium or storage solution, basically we want something that is going to maintain the viability of those cells with a good osmolarity and a good pH, something that's going to promote healing, and something that's easily available, something that has a long shelf life so that we don't have to keep rebuying it, and obviously something that's inexpensive. So I made up this little tooth solution storage pyramid chart. Top on our list is what we call Hank's balanced salt solution. And then milk is next, and then it goes down from there. I put Viaspan and any culture medium outside of the tooth because usually those are harder to get and unavailable. A lot of times people say, well, what about just putting it in water? The problem is water is no good. Don't use water. That actually has a bad effect on the teeth if you're going to try and reimplant them. So let's look at the good, the bad, and the ugly of a tooth storage medium or solution. Our first one up is the Hank's Balanced Salt Solution. It's actually available in commercially as Save a Tooth or EMT. It's got a good pH, a good osmolarity, a long storage time. Hopefully you don't have to wait 24 hours to get a tooth put back in. And you can buy it and put it into your first aid kit and have it around. As I said, the Viaspan is great, but they're not easy to get along with culture medians. The next one, and a lot of people have heard about this, is milk. Milk is very accessible and is around, and it gives us a good osmolarity. It gives us a good pH. We don't quite have as long of a storage time as that with the Hank's Balanced Salt Solution, but that's something that works very well. Some people say there's some antigens in there that interfere with the attachment process, but really that is probably next to Hank's Balanced Salt Solution is definitely in our top choice, top three. When I go backpacking, I don't carry milk with me per se, but I do take powdered milk with me. And that actually seems to work as well. Another good one that they've done tests on are these oral rehydration salts. I've never used those, but they are available, and I know people that do use them, and you can get up to 10 hours of storage with them. The egg whites work well. I don't backpack with eggs per se, but you may just be out camping or somewhere and have egg whites available and you don't have any milk, then I would use the egg whites. These two came up on some articles. I've never used them, but again, they've had good results in the lab with these. And so if you use these liquids, then a great one. I have a friend that hikes with coconut water. He likes to drink it. It does a good job. It's only a downfall or con, you could say, is it does have a low pH. So, but if that's what you have, then that's what you have. Saliva is readily available. Unfortunately, there are some destructive enzymes present in our saliva. And so you can use it, but just use it for a short amount of time. Gatorade or these sports drinks are readily available. A lot of people take them with them. The problem is they don't have a good osmolarity. They have a low pH. Basically, they're slightly better than water. Saline's kind of in the same boat. I mean, the tooth out of the mouth for 15, 20 minutes versus another 10 to 15 minutes. I guess you could use saline if you have it, but milk, Hank's Balanced Salt Solution, those are the best. Again, water, do not use water to store it in. And at one time, people were promoting contact lens solution, but really that doesn't seem to give us any better results. So there is our pyramid: Hank's Balanced Salt Solution, milk, your oral hydration or rehydration salts, and so on down. Now let's look at the tooth. It's fallen on the ground. It's dirty. We want to handle it by the crown. We want to try and keep that root moist so that we don't dry out those cells. We don't want to scrape or brush or scrub the root to get everything clean, but we do want to get it clean. So we're going to either rinse it, soak it, or do both. This is one that I just doused. I extracted it out of a patient. I threw it out the back door of my office into the dirt. And then I just rinsed it with a water bottle with a little bit of water to see what came off. And it did leave a few specks behind. With that, you can pick off any little specks with some tweezers or a sharp knife. And if it appears clean, then we can go ahead and reimplant it. So tooth management is to rinse it, pick it, and soak it while you are assessing other injuries and dealing with other problems. When we look at socket management, sometimes when a patient gets hit, the alveolar bone right here on the front can get crushed, and it can reduce the size of this socket. So if that's the case, then we want to deal with widening that depressed socket. We need to remove any blood clots that are formed in there. We don't want to go in and really curette things out. We want to just kind of rinse it with some water. If you carry a little baggie with you, you can cut a little corner off, fill it with some water, and you can rinse that socket out and get it as clean as possible. And then we re-implant the tooth. Once that tooth is in, we're going to guide it into position. There may still be some blood up at the top that didn't get out. And so just keep putting it until it's lined up with the other teeth. Hold it in place. Either you can hold it, the patient can hold it in place, or you can splint it. If you're in the backcountry and not going to get out for a few days, you'll want to start on antibiotics if you have them. If not, you want to go see a dentist as soon as possible. And if that's the case, when they come to my office, if the tooth is out, I'm going to then soak it in some Hank's balanced salt solution while I'm checking things. And I'll check things with x-rays. We'll re-irrigate the socket. We'll put it in. We'll splint it. We'll do a root canal therapy on it a week later. And if it has rolled around in the dirt, we'll check to see if their tetanus is up to date. And if not, then they'll go get a tetanus shot. So our treatment options for the knocked out tooth is reimplant it, and that's really your best option. And if not, store it in something that's going to give it viability to last. Because remember, with the avulsed tooth, time is not on our side. We need to get it back in or into something as quickly as possible. So now if we're going to add a little bit more to our first aid kit, with trauma, we have bleeding, so we're going to add some gauze, 2x2s or 4x4s folded up or cut up work great. You can fold them to however you need, but whatever gauze you have. Transport medium, milk, Hank's balanced salt solution, sutures, you might need sutures or some steri strips or even tape, something to splint with, something to irrigate with. And of course, we didn't mention this before, but our personal protection equipment, gloves, eye protection, that sort of thing. So let's look quickly at the soft tissue injuries. That's obviously going to be our cheeks, lips, gums, tongue, that sort of thing. With soft tissue injuries, we want to stop the bleeding, usually by putting pressure on there. Once we have that stopped, technically we want to repair the hard tissue injuries. We want to get them back into place, whether it be the bone or the tooth. It's not so much repairing the tooth itself, but it's getting the tooth into the proper position. And then we want to check the wound for any foreign material. And if you look at this picture, he's got a chipped tooth. Could that land up in his lip? It's a possibility. If they took a fall, they could have dirt and gravel in there. So basically, we're going to irrigate that wound to remove tooth fragments, dirt, blood clots, other contaminants that we may need. Here's an image of a tooth that got embedded in a lip. It looks like it came off of that tooth right there, probably number 8, and now it's stuck in the lip. If the injuries are minor, lacerations are minor, you don't need to do any sutures. They'll heal on their own. You can just stop the bleeding with some pressure. If the question is, when do I need to put stitches in? If we have wounds that are greater than 1 centimeter, that's just under 1/2 inch, or wounds that kind of fall open or gape open at rest, they probably need to be closed. Wounds where if you need to control bleeding and or want to get a good cosmetic result, we want to probably close those. So with that said, the vermilion border, that junction between the lip and skin, needs to be lined up. If you suture that up and that vermilion border's off by a millimeter or more, that's going to be noticeable when it heals. So the trick to getting that vermilion border lined up is to place your first suture to close the vermilion border, to make sure that's lined up and then close from there. Here's an example of a lady that has a cut that went across her lip. And you can see this one actually sealed up very nicely. They pretty much got that vermilion border lined up, and you really wouldn't notice that unless the light hit it just right. Okay, our journey is almost done. We're going to just look at first aid kits, dental first aid kits, that what do you want to put in your kit? And so that you can treat. You can buy commercial kits online. Commercial kits are at the drugstore or even at a sporting goods store. If you want to build it yourself, here's a list I put together that you want. So let's do a little comparison. So this is what was in the commercial kit, and this is what your do-it-yourself kit would be. Highlighted are the things that they have in common. So we do have a few more things in our do-it-yourself kit. If you feel comfortable doing those things or want to do those things, you may not have those things, but at least you may have the knowledge now of how to treat those things. If you're looking for an inexpensive temporary filling material, what I found is this Dentec Temperin. Actually, it's available pretty much everywhere I've looked, and it only costs a few dollars here in the US. And you know, if you go to the drugstore, they can also sell you some eugenol. But in reality, if you want to just buy clove oil, you can use that or have some clove oil with you or some cloves. And just remember, dental emergencies happen. And your knowledge has hopefully been increased, and you'll have a better toolkit when you go out into the backcountry so that you can now do dentistry on your own. So thank you so much for attending our lecture today from the University of Utah School of Medicine. I'm trying to get my screen to come back up. There we go. I appreciate your attendance, and that will end our lecture for today.